Assalamu alaikum. Our today's topic is chronic obstructive pulmonary disease, which is a very common scenario of our daily routine in our daily exam. First of all, we will initiate with its definition, which is a heterogeneous lung condition characterized by chronic respiratory symptoms, which can be dyspnea, cough, or any sputum exacerbation which can be due to abnormalities of the airway like bronchitis, bronchiolitis, or alveoli like emphysema that causes persistent progressive airflow obstruction. Minded, this definition is to be learned by heart because some examiners uh, they are fond of listing the definition, that is point to point definition, rather than making of it our own the time of exam. Then we classify COPD according to the GLOAL 2023 with like genetically determined COPD, which can include alpha 1 antitrypsin deficiency. Then COPD due to abnormal lung development, which can be due to childhood infections, due to premature births, or low birth weight at a time of delivery. Then third is environmental COPD, which can be due to cigarette smoking, which can be due to biomass pollution or exposure. Then fourth is COPD, which can be due to infections, like patient is having had recurrent childhood infections, which has now lead to chronic obstructive pulmonary disease. Then there can be overlapping of COPD and asthma, and there can be unknown cause also. Okay. Next thing is how to diagnose and how to label that the patient is of COPD. A diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production, or their history of exposure to the risk factors like smoking, tobacco, or fuels. But uh, it can be like this dyspnea can be progressive, persistent, which is worsening with exercise. Chronic cough, which can be with sputum, which can be without sputum even. Risk factors can be tobacco, which can be due to home cooking, heating fuels, or which can be fumes, gases, chemicals, anything. And along with this, with these symptoms, along with the risk factors, the most important thing when we label COPD is that patient on spirometry, that on post bronchodilator testing, the FEV1 over FVC ratio should be less than 0.7. That is mandatory in order to establish the diagnosis of COPD. So next thing is how we investigate a patient of COPD. We usually proceed with the baseline investigations. We go on. Remember, these investigations you have to tell uh, which investigation is done for what, to look for what. So complete blood count, we look for any infection patient is having and patient presenting with exacerbation of COPD. Then second thing is patient of smoking, smokers and those who are COPD, they are polycythemic, they have a high hemoglobin. Then chest x-ray. Chest x-ray, you very well know the findings of chest x-ray of a COPD patient. There can be hyperinflated lung fields, hypertranslucency. There can be tubular heart. Then serum electrolytes can be done, which in order to look for any hypokalemia if there is present, which is to be treated urgently because patient is being nebulized who is a patient of COPD, and this can exacerbate, which can lead to cardiac arrhythmias and death even. And the fourth thing which is important, which is the diagnostic test, that is spirometry with bronchodilator reversibility test. I will discuss it later. And fifth is echocardiography to look for pulmonary hypertension to rule out core pulmonale associated, which is a complication of COPD. Then fifth is IgE levels. IgE levels in order to rule out asthma, in order to rule out any allergic bronchopulmonary aspergillosis, because we very well know that patient if presents with COPD, we are making the differential diagnosis. Our first differential is COPD, Second differential can be obstructive airway disease like eczema. And number third is allergic bronchopulmonary asthma. Then the seventh test, which is a bedside test in order to check for exercise tolerance capacity, that is 6-minute walk test. This is the bronchodilators testing that either we can use SABA, that is short acting beta 2 agonist 400 microgram, or we can use 160 microgram short acting anticholinergic. And then we have to measure FEV1 after 10 to 15 minutes and 30 to 45 minutes respectively. And bronchodilator testing of FEV1 over FVC ratio should be less than 0.7 in order to confirm that it's non-reversible airflow obstruction. If there would be, that is going towards asthma. And with this bronchodilator reversibility testing, we classify this according to the airflow obstruction COPD according to the GOLD classification: mild group, moderate group, severe group, and very severe. Mild group, first we look for FEV1 over FVC, which should be less than 0.7. Then we classify according which is the category, which can be mild, moderate, severe, or very severe. If FEV1 is more than 80%, it's mild. If it's 50 to 80%, it's moderate. If it's 30 to 50%, it's severe. And if it's less than 30, then it's very severe. These are the 4 GOLD classification, which are very important and frequently asked in the examination. Then the next thing is MMRC scale. That is also important because when we are taking the history, which I will be discussing later, how to take how a patient of COPD can present with, and how we are going to take it in our exam. For that MMRC scale, you should be remembering it. There are 4 grades. Grade 1 is patient is breathless only on strenuous exercise. Grade 1 is when patient is short of breath, when he is hurrying on level or he is walking uphill. Grade 2 is he is slower than the people of his same age on the level because of the shortness of breath. Grade 3 is he cannot walk even 100 meters and he gets short of breath. Grade 4 is either patient is breathless even on dressing or on leaving his house. So this is MMRC scale. Then the third thing is CAT score. This is a score, but you should knowing the name, because usually this score is given to the patient to fill in, and according to the then we categorize it from 0 to 10 numbering, and then we have to manage it accordingly. You will see it later that there are certain how to classify according to ABE tool. So here is ABE assessment tool. Previously in 2022 there was gold ABCD tool, and now it has changed in 2023 to ABE tool, in which there is, once we have diagnosed spirometrically and we have assessed the airflow obstruction, which classify patient falls in, which can be gold 1, 2, 3, 4, and then we are going to treat it. How we are treat ABE tool, that is you have to check how many exacerbation histories patient is having per year. If the patient is having exacerbations more than 2, more than and equal to 2, and 1 hospitalization, more than 2 exacerbation and 1 leading and 1 exacerbation causing hospitalization with MMRC 0 to 1 or CAT less than 10, patient is going to be categorized in E. Okay, either regardless of MMRC and regardless of CAT, patient is having more than 2 exacerbation and hospitalization more than 1, patient is categorized as E. And if patient is having only 0 or 1 moderate exacerbation with no hospitalization, then we classify as on the basis of MMRC and CAT scoring. MMRC if is 0 to 1 and CAT if less than 10, it's A. And if MMRC is more than equal to 2 and CAT is more than equal to 10, then we label as this is B. So here's the treatment management plan, what we give to the patients if Patient falls in category E. So that is patient, we are going to give him LABA plus LAMA. That is long acting bronchodilator agonist, long acting beta agonist, and long acting muscarinic agonist. And A falls, if the patient falls in A category, then it's the bronchodilators which we are going to use. And in B, patient if it's falling, then we are going to give LABA plus LAMA. These are the certain commonly used medications, that is SABA, which can be salbutamol or tibutaline, LABA, that can be salmeterol or formoterol, then in SAMA it can be ipratropium bromide, then LAMA eclidinium bromide. Achha, these LAMA medications you have to learn by heart because these are the new ones. LAMA includes the eclidinium bromide, revifenacin, eclidinium. Then LABA plus LAMA includes the formoterol plus glycopyrronium. Then LABA plus inhaled corticosteroids includes the formoterol plus budesonide. Then is LABA plus LAMA plus inhaled corticosteroids, which is available in the form of Trembo. Then there are certain phosphodiesterase 4 inhibitors, that is roflumilast. Then there are mucolytic agents like carbocysteine. So here are the certain factors where we are going to add on inhaled corticosteroids in on LABA. If patient is having history of hospitalization for exacerbation and there are more than two equal to moderate exacerbations, then and patient is having eosinophilia more than 300 cells per microliter, and patient is having any history of asthma. So in this we can use. We can also use if patient is having one or more exacerbations and eosinophil falls in 100 to 300. Achha, one thing I just missed, I think so, in explaining this, that in category E, where there are more than two exacerbations and more than one hospitalizations, there if patient is having eosinophilic count more than or equal to 300, there we can use LABA plus LAMA plus inhaled corticosteroid. So similarly with what we were talking about, the indications of inhaled corticosteroids, where we are strongly favoring to its use, and against uses that patient is having pneumonia, repeated pneumonic infections, and eosinophilic count is less than 100. So we are not going to use inhaled corticosteroid in that. How and certain, it's a malpractice which we are doing, that we used to give oral glucocorticoids on a very high role. How it should not be given. They play a role in the because they only role in they have acute management. They have no role in the chronic daily treatment in the COPD. And then certain antibiotics can be used, that is azithromycin 250 mg or 500 mg 3 times per week, or erythromycin 250 mg BD for 1 year. In patients prone to exacerbation, reduces the risk of exacerbation. There is no role of antitussives or vasodilators. Then exacerbation of COPD. We are going to label a COPD patient that he presents with exacerbation when patient is having dyspnea, cough or sputum, which worsens over a period of less than 14 days. Any event which is taken in less than 14 days period, that is called as exacerbation of chronic obstructive pulmonary disease. And how we are going to manage it? If patient presented with dyspnea, so we are either going to give him LABA or LAMA if patient responds to it. If not, then we are going to add both of them, LABA plus LAMA. If patient is not treated with them, if not responding to this treatment, we have to look for the inhaler devices, inhaler technique. We have to look for non-pharmacological treatments, and we have to rule out other causes of dyspnea. That can be any cardiac reason. Then if patient is having exacerbation, we can give either LABA or LAMA, same as we did previously. If not improve with it, we can combine with LABA plus LAMA. And we have to look if patient is having eosinophilic count more than 300, we can combine inhaled corticosteroids with it. If patient not responding to it, we can go for azithromycin as discussed. I discussed it. The azithromycin 250 mg or 500 mg 3 times a week, or we can give roflumilast. If patient is having chronic bronchitis and patient is having FEV1 less than or equal to 50%, that is, patient is either severe 30 to 50% or very severe less than 30, then we are going to go for roflumilast, which is phosphodiesterase 4 inhibitors. This was the for exacerbations. Then for stable COPD, there are certain goals for treatment. We are going to reduce the symptoms in order to improve the health status of the patient, exercise tolerance of the patient. We have to reduce the risk to prevent disease progression, to prevent complication, to reduce mortality. Then there are certain non-pharmacological management, which includes uh, smoking cessation, physical activity. Then there are certain vaccines which are recommended globally according to the gold classification, which is include influenza vaccine, pneumococcal vaccine, pertussis vaccine, COVID-19, and shingles. Pulmonary rehabilitation is very important. Nowadays, patient education, nutritional advice, psychological support, and advising aerobic exercises, they are very much helpful for the patient. Then follow up of the patient. Follow up, we should review the symptoms, we should review the risk factors, we should review the exacerbation risk factors, history, the eosinophil levels. We have to assess whether patient is uh, adherent to the advice, inhaler technique is correct or not, and whether he is following the non-pharmacological, that is smoking cessation, is there or not, there whether there is aerobic exercise, physical activity, what about the vaccine status, that should all be assessed. And then adjustment of the pharmacological treatment. If patient says that he is not improving, then there may be escalation or de-escalation. We can switch to the inhaler devices, we can change the drugs, we after looking upon the clinical response and the side effects of the drugs. Then when to use the supplemental oxygen, that is long term oxygen therapy, which can be given 10 to 18 hours per day, on average 16 hours per day. We give supplemental oxygen when there is arterial hypoxemia, and we label arterial hypoxemia when there is partial pressure of oxygen is less than 55 millimeter of mercury or 7.3 kPa, or saturation is falling less than 88%, or partial pressure of oxygen is more than 55 but less than 60, with signs of right heart failure or hematocrit more than 55, and to keep the saturation more than 90%. We have to recheck in 60 to 90 days if further supplemental oxygen is required or not, and the therapy which is we are giving, it is effective or not. Then the next thing after long-term oxygen therapy, which can be given to the chronic obstructive pulmonary disease patient, is the non-invasive ventilations. Non-invasive ventilations, there are certain indications which includes if patient is having respiratory acidosis, patient is having partial pressure of carbon dioxide is more than 6 kPa or more than 45 millimeter of mercury. There can be severe dyspnea with clinical signs of respiratory muscle fatigue. There can be use of accessory muscles, or there can be retraction of the intercostal muscles. There can be persistent hypoxemia despite supplemental oxygen, and patient GCS is more than 8. Less than 8, we cannot give non-invasive patient, because patient cannot follow the commands, he cannot take deep breathing. Then comes the invasive ventilation. Invasive ventilation, there are certain indications for that also, which includes hemodynamically unstable patient, pH less than 7.25, despite of the supplemental oxygen and non-invasive ventilation. If GCS is falling less than 8, patient is confused, lethargic, he is unable to tolerate non-invasive ventilation, he is unable to remove the secretions, and patient is already post respiratory and cardiac arrest, then we are going for invasive ventilation. Then the last thing which is important, which is slightly to be discussed in COPD, is surgical and interventional therapies, which includes bulectomy, which can be if patient is having bullous. Not too many billas can be removed from the lungs. However, one or two which are large significant endoapical areas, we can go for bulectomy. Then comes the endoscopic lung volume reduction surgeries, which can be there can be use of endobronchial valves, the lung volume reduction coils, the vapor ablations. If patient not responding to both of these, then we go for the lung transplantation. And there are certain indications of the lung transplant, which includes pulmonary hypertension, board index 7 to 10, and patient is not a candidate of bulectomy or lung volume reduction surgery. That's all for today. Um, I will share with new certain slides that were missed was one of how to classify the exacerbation of COPD. There are certain on the basis of mild, moderate, and severe on the basis of certain factors, which includes the respiratory rate, heart rate, saturation, and the CRP levels. This is for um, that's present in the Oxford. Then there are certain complications which are to be discussed. That a COPD patients can how they can present. They can present with core pulmonale. Patient can present with CO2 narcosis. Patient can present with polycythemia. Patient can develop, if patient is having long-term COPD, he can develop CA lung. That can be non-small cell, that can be small cell. Patient can have repeated chest infection, ICU admissions, and he can have risk factors or side effects of ICU admissions, the infections patient can be prone to. And the last thing, which is that COPD and COVID patients, how to manage those if the patient is having mild COPD, mild COVID, and COPD. We are just going to go for COPD exacerbation therapy and low intensity exercises therapeutic trials. However, patient is having moderate COVID, patient is having infiltrations in the HRCT, then we are going to give controlled oxygen along with systemic steroids and anticoagulation. If patient is having severe COVID, patient has developed ARDS along with COPD, then we can give non-invasive ventilation, high flow nasal therapy, prone positioning, and we can go for invasive mechanical ventilation. That's all for today. Thank you so much. Hope you would like and you will subscribe the channel. Thank you so much.